Bismillah ar-Rahman ar-Rahim. Thank you, GIS committee. It's my pleasure to share this case, intra-coronary imaging in complex acute coronary syndrome. The question actually, what is complex acute coronary syndrome? Acute coronary syndrome and geographically complex culprit lesion or complex coronary anatomy. Complex culprit lesion, intraluminal filling defect, black ulceration, black irregularities or haziness. And according to the angiographic hallmark of complex culprit lesion by Ambrose criteria, it is haziness, ulceration, intraplaque dye penetration, and intraluminal filling defects. He classified into simple lesion and complex lesion type 2 with multiple irregularities as well. While the complex coronary anatomy, according to the randomized trials of imaging versus angiographic guided BCI, it is heavily calcified lesion, unprotected left mean, CTO, bifurcation, long lesion, and ostial location of major epicardial vessel. And this is the European guidelines and recommendation for the role of intracoronary imaging in acute coronary syndrome, especially obstructive lesion with ambiguous angio, multivessel disease, we don't know the culprit, and hazy lesion, calcification, tortuosity, eccentricity, or atypical presentation with complex anatomy. And recently, the chronic coronary syndrome highlighted the importance of imaging to be class 1A recommendation for complex anatomy, left mean, true, bifurcation, long lesion. And of course, all of us know that acute coronary syndrome, multiple causes, most commonly plaque rupture, erosion, calcified nodule, but there is also another important topics, SCAD, embolism, spasm, Takayasu arthritis, and all other varieties, myopercarditis, Takotsubo congenital. So not every case need a stent, but every patient need a diagnosis. And this is the message of this case, actually. Our patient, 48 years old, female patient, not diabetic, not hypertensive. She is heavy cigarette smoker, presented with severe typical chest pain, 8-hour duration. And once arrived to the emergency department, she developed cardiac arrest in ER, VF, and CPR done 5 minutes. To DC shock given for her, and after successful CPR, she intubated, mechanical ventilated, and vasopressor started, and ECG done showed this T-wave inversion with little bit elevation in the anterolateral leads. So we took her to the cath lab. This is normal right coronary artery actually, and this is the left system. There is very critical lesion at the ostium of LAD with occlusion, total occlusion of the mid-LAD. What I call actually, or mentioned in literature, it is massive macro embolization, including the mid part of the LAD from a huge burden of thrombus in the ostial part of LAD. It is spontaneous distal embolization actually causing occlusion of the mid part. So immediately I use the extraported catheter many times, maybe 5 runs or more, and this what comes out, huge burden of threaded thrombus actually, and still the flow is TIM1 flow. So I decided to use intracoronary low dose thrombolysis. We have at the time tenecteplase 3000 given, bolus direct distal in the coronary artery through the extraported cath itself. And after I give the also intracoronary vasodilators, the flow is improvement to little bit TIMI1, TIMI2 flow. So I feel this is a time for imaging to know the ostial lesion, actually what is the nature, what is the burden, what is the residual thrombus burden for this ostial lesion actually. So OCT done for this patient, showing a huge black burden in the ostial location. And this longitudinal axis is showing a high lipid content, black burdens. And there is also layered black pattern, which is most commonly encountered in patients having subclinical repeated acute coronary syndrome events, and also macrophage infiltration in some area. And this is also the rupture of the black distal shoulder, but most importantly, there is red thrombus. Still, there is a huge burden of red thrombus as the distal shoulder of the huge black, actually. This is the red thrombus correlated actually with the haziness of the angiography. So it is actually large residual burden of the thrombus, despite we make 5 runs of the aspiration, and a huge burden of thrombus comes out also. So in this clinical situation with a huge burden of thrombus, so my thoughts comes to protect the microvasculature and not making stenting at the time, actually. So I decide to defer stenting. I decide to, especially this patient having already macroembolization that I cleared, and a patient have borderline blood pressure, and of course we need to protect the microvasculature. So I decide to defer with tirofiban for 48 hours. And patient shifted to ICU, still nitrotoluene, vasopressors, tirofiban given, and all other medication. And I bring her back after 48 hours. There is clearance of the haziness of the thrombus in the distal shoulder, was huge black. So antimisary flow distally now. So I decide to deploy a stent. Actually, after I repeated OCT, there is no little bit involvement of the distal left main or ostial circumflex. So I decide to make precise ostial stenting for her, and this is the final results. And this is before, this is after. Echo done for this patient on admission, and it was 5 days before discharge. We discover there is LV thrombus, and we give her Plavix, warfarin, and follow up with me an outpatient. But this patient having, after 1 year, chest pain. Actually, it is not typical chest pain, so other team was covering on call and did angio for her at the time, after 1 year from intervention. And we noticed there is complete resolution of ST segment in the ECG of this patient, and TIMI strip flow distally, and most importantly, the function of the LV, which was very severely impaired on presentation. It is now nearly normalized LV systolic function. So, my final take-home message: intracoronary OCT IVUS is mandatory in complex high-risk acute coronary syndrome. Intracoronary imaging gives us a new insight about the different ACS pathophysiology and black vulnerability, adding detailed information about culprit lesion and their characteristic, which is valuable to guide optimal ACS treatment. And intracoronary imaging choice depends on lesion depth and location. OCT is excellent tool for superficial layer imaging in ACS if we need to make clarification for vulnerable plaques, plaque rupture, erosion, calcium nodule, or unstable SCAD, or thrombus type, red or white thrombus, while the IVUS is excellent tool for ostial left main, CTO, long lesion, bifurcation, deep calcium penetration. And finally, a large residual thrombus is much better detected by OCT. Of course, it can help for defer stent decision making of a huge burden of thrombus, and protect the microvasculature and avoid what we call the microvascular tissue no reflow phenomena. Thank you very much.